Okay, everyone. So I haven't jumped onto one of these in a little while, but I'm going to go over a couple different topics today. The thing I really want to focus on and highlight on is the concept of spinal stenosis. As a background, I'm a spine surgeon here in Dallas, Texas. I'll jump on these for about 20, 30 minutes at a time. I'll go over a different concept, different questions. I can't obviously give medical advice, but usually what I found it to be the most helpful thing is I can kind of just answer basic questions on like what anatomy is, what is stenosis, what is sciatica, and then talk about some of like the new treatments that spine surgeons are working on. And we kind of go from there. So kind of getting right to it. And no, this isn't an outreach in terms of make appointment and all that stuff. This is more so just jumping on for 30 minutes at a time and going over a couple different concepts. Let's see if I can fix that a little. Sorry, I haven't jumped onto a live in a little bit. So some of my IT stuff and coordination stuff are a little off, but let's just get right to it. And then I'll try to get some questions here. We'll kind of do some rapid fire questions and all that. So in general, the thing I want to talk about mostly today is spinal stenosis. It's a big word, but it doesn't have to be. Spinal means the spine. So it can be the cervical spine, be the lumbar spine. So it's the lower part of the spine. It can be the neck, thoracic spine. Stenosis is a fancy word for the nerves all getting squeezed, all getting pinched, all getting compressed. So if this is the lumbar spine and you're looking down the tunnel of the spine, so again, here's the nerves coming off that go to your legs, thighs, all this fun stuff. But down the tunnel is where they're running down through first, and they split to go to different areas. Spinal stenosis is the squeezing of the center area. Central stenosis, spinal stenosis. What causes that? Well, it could be like a million things, right? It could be a bullet was shot in there and, squeeze that area. Well, that's obviously not super common unless you worked at University of Miami for a while and saw that infrequently, unfortunately. But in general, the number one thing of what causes spinal stenosis is arthritis. Just like you get a callus formation on your hand, just like this when you're bad golf swing, working outside, push-ups, working out, who knows? You can get that on your joints. These are called the facet joints. So that's kind of what moves. The rotation are the facet joints, kind of like a knee joint or an elbow joint. When those get some wear and tear on it, normally it's like a thumbnail sliding on a thumbnail. It's nice and smooth. That's what cartilage is. But arthritis is God's way of trying to protect us, right? That's kind of like, what do we do before we had spine surgeons? We grew extra tissue trying to harden that area to lessen the pain. That's kind of how to think about arthritis. We grew extra tissue to harden that area to stop causing pain. Now, of course, that could cause more pain. I'm not naive to that, but hear me out. Like, why do we even have arthritis? You got to think about it. So you grow arthritis in these joints here. Yes, it causes pain, but maybe eventually it gets so hard, so thickened, that doesn't hurt as much. Well, here's the problem. Sometimes that arthritis, let me grab this spine model here because it's, I like this one a little better. Sometimes that arthritis, I got a couple different cameras here, so I'll point to different ones. If this is the neck or if it's more so in the lumbar spine, those joints get thick in tissue and it's out here in the muscle. Well, whatever. You got bone spurs in the muscle. It hurts. At the end of the day, no big deal. But when it starts to squeeze down this canal here, the thickened tissue, the ligamentum flavum, that's like a protective tissue on the back here, starts getting thicker, bigger, 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 just like you get callus formation here. Just like if you wear bad shoes and you get a callus formation, that's kind of what arthritis is. And then it starts to squeeze those nerves. Over time, it starts to harden. That's kind of what a bone spur is. Like, where did it come from? That bone growth was from a tissue that hardened and became a bone. Spinal stenosis, the squeezing of all those nerves. Now, realistically, just because you have spinal stenosis, the diagnosis, say you got an MRI, you've never had a spine issue in your life, you get an MRI and you have spinal stenosis in the lumbar spine. Well, it might be a who cares. You might not need to do anything about it. It kind of depends on what's causing it. If it's an arthritic thing and it's not bothering you, you don't have weakness, you don't have numbness, then fine. You can watch spinal stenosis as long as it's not interfering with your life or causing certain nerve damage. I would think of it that way. We'll kind of get back to a couple other things, but let's go a little more over. We'll get into the treatment of spinal stenosis in a minute. But in terms of other stuff to cause it, so that's arthritis. You might be thinking, well, I'm 45. Do I have arthritis? Probably a little, like everyone does. But here's another way you can get it: a big disc herniation. So there's a disc space here, imagine right here, but for the purpose of this live, pretend there's a disc space here. A massive disc herniation could come out, hit those nerves, squeeze that canal, and that's another common form of spinal stenosis, is a disc herniation. That disc herniation can also hit these nerves, numbness and tingling down a leg, down a butt, down the back of the thigh. That's the presentation of sciatica or a radiculopathy, a pinched nerve shooting down the back of the leg, side of the thigh. Spinal stenosis can cause those things. Additionally, especially if you're like 60, 70, you could get a condition called neurogenic claudication. And everyone at home's like, what in the world did he just say? But that's like the number one thing I see. I don't know if that's 100% true. That's the number one thing people reach out to me for or something like that. I don't know the ranking. But neurogenic claudication is when you have such bad spinal stenosis here that when you're out and about, you have to get the shopping cart to lean forward to open that spinal canal. Just the nerve juice, think of it that way, isn't totally getting through. Your legs get heavy. It's like you're wearing cinder blocks on your leg. Your legs just aren't working that well. That could be from lumbar neurogenic claudication. Another thing that can cause spinal stenosis, and then we'll get to treatments and all that stuff. I know there's we're going through a million things here in maybe 20 minutes, is if you get such bad arthritis in the joints, or if you get a hyperextension injury. Hyperextension injury is my favorite thing to treat. And you get a pars fracture in the back here. So these are all the bones in the back, the lumbar spine, all the bones in the back. You get a pars fracture. So this bone is wiggly. All your stress goes through that disc space. When this bone is wiggly, if you have a pars fracture, and when that happens, your spine can start, this is more extreme than it really is, but dislocating, where the bone starts sliding forward like that. That's another thing that would then squeeze that canal. If you can imagine, if this is your spinal canal, that pin's going through there. If one bone slides this way, I'm pulling all of those nerves, if that's showing up well at home. So that's another way you can get spinal stenosis, is spondylolisthesis. Again, I hate using all these big words. That's why I'm trying to simplify it. But there's bones slipping like that. Spondylolisthesis is a form of spinal stenosis. All right, so a little exhausted from all that already. But in general, that's kind of what it is. Disc herniations, spondylolisthesis, arthritis are the major causes of spinal stenosis. You also could be born with it, something called neurogenic something called congenital stenosis, where, and the way I describe it to patients is, in general, not a big deal if you have congenital stenosis. You're born with it. You might not ever know you even had it. Well, what does that mean? It means if everyone's spinal canal is this big, yours is actually this big. And I just tell people it just means your nerves and spinal canal can't take a joke. And this is an actual size. Maybe it's, I'm not going to do actual size, but think of it this way. If you have congenital stenosis, your spinal canal, if everyone else is this big, yours is that big. So it's just a smaller area. And in general, it's these pedicles, these walls here are just shorter than the proportionally. So you just can't, I say your spine can't take a joke. To be clear, having any of those conditions we talked about just radiographically doesn't mean you need surgery. Again, I'm a surgeon. I do surgery all the time. I like surgery. It's fun. It's good. Great outcomes. Patients are happy. High fives. But you don't need to treat the MRI necessarily. It's more about the presentation. Now, to be fair, if people are seeing me, they have usually the symptoms and then the MRI. But, say you got one of those full body MRIs and they said you had it in the lumbar spine and you're totally asymptomatic, maybe see a spine surgeon, but probably aren't going to need anything. You don't need to treat it just because you have it. Okay, so what is the treatment? Well, it kind of varies. I would think of it as like your car. When you go see a spine surgeon, one, it depends on what car place you take it to, what spine surgeon you take it to, and their background, their belief, their training. Two, it's like, what type of car is it? Is this like a super old car that just rolled down the toll road, caught on fire, and you're bringing it there, asking for it to get totally fixed up? Might not be able to get it back perfect. Or is this like a McLaren F1? It has a little bump on it, and you just kind of need to fix that little bump type of deal. The other way to think about what's the treatment for it is, as a spine surgeon, I'm always thinking about if there's any subsequent surgery. I don't want to hose the next surgeon or hose myself later on. So I'm trying to do the smallest thing possible. So that way doors are still open, options are still open. Or sometimes it means doing the bigger surgery. So that way they don't need a bigger surgery in the future or an additional surgery in the future. So there's a lot of ways to kind of think about the different things. There's not one specific treatment just based on that condition. The only time that's an exception, for the most part, is if you have that bone fracture in the back, that isthmic spondylolisthesis. That is pretty much always an indication for a fusion. But just having the other things doesn't mean you need a fusion. But fractures, spondylolisthesis, that's an isthmic type, not to get too many technical words here, that is an indication for a fusion. Before you're like, no, fusion suck, no way. Okay, fine. First of all, they don't, but We can kind of come back to this. But if you had like a fracture down here, that's where you get the spacer in here that opens up the nerve tunnels, restores the height. You kind of have to replace that disc, and then you get a pedicle screw fixation so it doesn't keep slipping, holds it into place. But honestly, the majority of cases of spinal stenosis I see are neurogenic claudication. You know, these older patients that are 60, 70, sadly 80, but maybe if you're 80, go ask your spine surgeon down the street, not me. They don't need a fusion. Even if they have the instability, even if they have the spondylolisthesis, it's probably stable. Almost always, I don't know about almost always, extremely frequently, I could just do something called a ultrasonic laminectomy. The laminectomy is the key term there. I use this ultrasonic device, but that's a little beside the point here. But for real, it's a small incision. This is a writing utensil. Maybe it's that big. And this isn't me being special. I'm sure many other spine surgeons around my training year do it the same way, where just by comparison, about that big. So not too big, not too small. It also depends on how many levels we're doing, how big the patient is, stuff like that. And you just kind of shave off the back and do a laminectomy and get on your way. I see them at 2 weeks, 6 weeks, sometimes 3 months. And I would guarantee you most spine surgeons would say it's their favorite surgery just because it's super powerful surgery without any rods, screws, hardware, and patients bounce back. It's called laminectomy. We do it all the time. It's a great treatment option for spinal stenosis that doesn't need a fusion. Okay, so what's the cure? Well, cure is kind of a very big, what does that mean? Also, like you're getting rid of it forever at every single level. I don't know about that. There might be some special medication that comes out here and, who knows how many years, 20 years, 30 years, that helps prevent a certain tissue in the spine called the ligamentum flavum from getting thick. That'd be crazy, but that'd be great in a way. I mean, maybe not great for me, but that'd be great in a way. But that sounds pretty crazy, pretty tough. So curing it from the entire body seems a little tough. Things you could do. Here comes my 7-year-old. So let's see what he's going to say here. Hi. Oh my God, that's amazing. Do you want me to show everybody? Sure. Okay. Speaking of spinal, look, we can even make this a spine thing. He just drew this during his downtime. Great job, Munchkin. Fun fact. How many bones are in the neck of a giraffe? The same as a human. 7, but that was good. Yeah. All right, bye. That's a fun fact. I don't know if this is 100% true. All mammals have the same amount of bones in the neck, and that's 7. We have 7 bones in the neck. I kind of think that's like pretty true. I'm sure ChatGPT could answer that for us. So let me get back to it. I'm throwing a little off sides here by my little man. Let me just get to questions now because I'm totally throwing off sides. So we'll jump to this platform here. Thanks, everyone. I've tried several times to send you my MRIs. I guess I've not done it right. I need a second opinion from Reggie. Reggie, I don't know what to tell you. I'll just call my office and they can get you set up for a telemed appointment. But yep, we do need x-rays and MRI. I actually got a 1-star review on Yelp from someone because they were mad we wouldn't see them without their imaging. And I mean, what am I supposed to do? Just be like, cool, let's get imaging, but get imaging and then reach out. Like, I don't know. So yes, please send in your imaging because they're all someone's going to talk to you and be like, yeah, let's get some imaging. We'll go from there. Someone else said, how about an XLIF? I like XLIF. XLIF's another type of fusion where you go in under the rib cage. Usually you can do that at L1, 2, L2, 3, L3, 4, sometimes at 4, 5. Can't do it at L5, S1. From Steve Johnson, is laminotomy a temporary fix? Let me answer your question by rewording that. Is a laminectomy, not to split hairs, and I'll go over the difference of a laminectomy, laminotomy here in a minute, but is a laminectomy a temporary fix? Maybe, probably not, but maybe. And if you're like, well, that's a terrible answer, what does that mean? Look, we're just shaving open and opening up this area in the back part of the spine. Could you get additional disc height loss and then squeeze those nerves later on? Sure. But that, honestly, it's not too likely. And it also depends on a lot of other factors. But okay, so what do you do? Now just do a fusion as the first thing. Doing a laminectomy is a great way. Most patients will not need an additional surgery. And again, it depends. Like, am I doing that on a 20-year-old? Well, I'm probably not doing a laminectomy on a 20-year-old. It's probably like a 67-year-old anyway. Fine. We'll come back to that argument. But yes, usually a laminectomy is the only surgery you'll need at that level. Now, that's not 100% true. Say it was a laminectomy above a fusion. maybe like 40% of those might need a fusion later on, just from the continued wear and tear of that disc space. I don't know if that necessarily means you should go do the fusion right away, but is it a temporary fix? Maybe, maybe not. If and that's where the surgeons might instead recommend a fusion, because the fusion is kind of the definitive fix. It's reestablishing the height, locking it into place, but it's a bigger surgery. If we can avoid that, we can avoid that. So in general, I say, yeah, it's a temporary fix, but I really respectfully tell some of my patients who are like 75 with heart disease, I'm like, maybe you need another surgery in 30 years from now. And they're like, well, I'll be dead in 30 years. I'm like, okay. Either way, I would say it's a temporary fix, but it should last a very long time. And the more definitive fix of fusion, which certain pathologies are more indicated for that. Good. Let's get a couple of questions. I'm 28 years old. This is from Carlos. Carlos is saying, I'm 28 years old. After 15 years of pain, I'm finally getting surgery next month on the C5 disc. Okay, great. From Kathy, I had a laminectomy with a fusion. Yeah, that's not uncommon. You do a laminectomy and then do a fusion also. Not uncommon. I have a 360. Okay. Trying to get these questions, see if there's any questions coming in. Now I have, a lot of questions coming in. I'm sorry, everyone. Now what do I do for bone spurs and facet hypertrophy? Severe back pain, back my legs, from Amber. Amber, and someone's sending me gifts. Stop sending me gifts. I appreciate it. But stop sending gifts. I'm not trying to be rude about it, but save your money and finances for other people on social media trying to make a living on it. I'm just out here spreading the good gospel, hopefully. So thanks for the gifts, but don't send them. Sorry, I usually tell people that. I forgot. So what's good for parasites? That's a weird question. Are ablations worth it? Yep, I definitely think ablations are worth it, Daniel. So think of the back pain you're having as a couple different things. So the stenosis can cause back pain, those pinching the nerves, but a lot of times the stenosis and the cure for stenosis is getting the diagnosis. Your back pain might just be these joints rubbing. What a pain management doctor would do is they put a little ablation device around this joint and kind of burn the sensation nerves around the joint. And that is a very effective way to alleviate back pain. Now, some say, well, it's not forever. That's true. But if it is for 6 months or 6 years, that's still better than the alternative, because in general, this isn't always true, but a spine fusion for back pain is not a good idea. They just don't have the highest success rates. And you're like, well, what happens? Does it explode? No, it's just that it doesn't always cure the back pain. And if you're like, well, why would you do this in the first place? Fair. Because back pain is like tough. Is it this disc, this disc, this disc, this disc, this joint, this joint? Is it the muscles? Is it the alignment? Well, sometimes, not infrequently, and kind of the only time I'll do fusions for back pain is if their spine looks 100% perfect, but it's like one terrible looking disc. It's bone on bone, or it's sliding, and they don't have the nerve pain, but it's like, I'd say 100% sure that it's that one area. Then a fusion could be indicated, and there's a lot of debate on that. If it's just at one level and you're positive. If it's like a little questionable and you fix it and they're like, oh, I got 40% better. Well, there's probably other areas in the spine, or they have under immunologic issues like aphylactic spondylitis or rheumatoid issues that are causing the stuff. So there's different ways there. Kath, do I consider myself conservative? I do. And the way I can kind of prove it, and hear me out, because I think there's like a really good argument, is I'm from Dallas, born and raised. My wife's from Dallas, born and raised. My family all lives here. I'm not moving. Okay. So you're like, how does that mean you're just conservative? Because I need a good reputation here, right? Like I'm getting the age, or my friends and I are getting the age where now I'm operating on them and our family members and stuff like that. So I need a good reputation. And so part of that is being conservative. And, bluntly, I'm pretty darn busy. This stuff we're doing here makes me very busy. So I don't need to go do bigger surgeries than I'm not out there looking to do fusions. I could do laminectomies all day and microdiscectomies all day and have a nice, good, happy life. So I guess that's my proof is in the pudding. I'm here locally. I'm never moving probably. And I want to have a conservative reputation. I want people to come to see me and know that I didn't offer them surgery. So that's how I kind of jokingly prove I'm born and raised here in Dallas. I'm not going anywhere, and kids are going to go to school here, or they go to school here. So am I conservative? Yeah, I think that's my proof that I'm conservative. How about that? I guess I could show you my surgical numbers, but what does that even mean in a way? A couple other questions here, and then I kind of want to circle back to the cure for the spinal stenosis. Someone's asking, why am I in my scrubs cap? Well, I say this pretty much every time. Someone always asks that. I say, I was wearing a golf shirt and we just had a family swim sesh. So It's easy. I can just throw this on. This is the same one I wear every time. It just sits on that chair. It probably smells like skunk. And I put this on or it's not skunk. It probably smells nasty and I sweat in it. And it's the same one I wear every time I do these live. So pretty much it's just an outfit I put on for these. No, I'm not in surgery. No, this is not my office, or it's like my little closet I do this in. So Recum Tech. Yep. That's where I went to med school, the Harvard of Texas. Can you show me a pedicle screw? Yep. This is the screw. So when someone gets a spinal fusion, this is a minimally invasive screw. And if you're at home being like, that does not look minimally invasive, you're right, but it is, because it's the best way to describe this. When a screw goes in, this is the only thing that's left on it, is that part there. So it's this thing called the tulip, and this goes in the bone. Well, to get that down there, you got to get down to the bone. And if you have tissue, like this is your spine, hello, you lay down on the bed, and you have your muscle tissues probably this high up, then you have to dissect open all that muscle to see the area. Not anymore. In many, many surgeries I'd say the overwhelming majority of fusions I do a CT of the patient. I put on this augmented reality headset. It looks like a fighter pilot thing. And then I can make a stab incision over that area, and I dilate through the muscle. So I don't have to cut all that muscle. I don't have to splice it all open like the old school way. Hold on. Dissect through that area, and I can put this pedicle screw in right there. And then let me actually show you this model here. So this is like with it in, the tissues here. This is all muscle. This is all fat. And then after you're done with the case, you put down this device and it breaks it off, and then they're left down here. So that's what they look like. But these are the minimally invasive screws. They have towers in a way. They'll be tunneled down there with these tools. They even go out to here. You put it in there, and then you break it off. And so then they're minimally invasively down there. So a minimally invasive fusion is how I do the majority of my fusions. In fact, I talked to a patient who was like a year post-op from someone else, and they said, "Oh, I didn't do surgery with you because it wasn't a minimally invasive fusion." I was like, "Oh, I guess I don't even call it that, because I kind of consider that a marketing term." I guess all my fusions, I use that same type of minimally invasive screw. I guess it's kind of like when you grow up only doing minimally invasive surgery, you don't call it minimally invasive surgery. I just call it surgery in a way, as opposed to like wide open surgery. But that one kind of stuck with me. So I was like, oh, I'm doing a minimally invasive fusion on you, but it sounds like a little marketing ploy to me in a way. But yeah. Sorry, I'm watching my cute little 3-year-old. Oh, last day of him being 3. His birthday is tomorrow. Taking a nap right now. So looks like he's about to wake up, and I have to go if that's the case. So let me get to a couple more questions here. Again, appreciate the likes. This is all on YouTube, so you can watch it on YouTube. You can rewind it back. Rosa, that's a good question. I hate the answer here. You say, do I take Canadian patients? I don't. I did for a good while, but truthfully, it's just a big hassle, unfortunately, because in general, maybe your MRI is like a year or 2 old. I ask you to get a new MRI, and it takes you like a long time to get it. And then just the follow-up's tough. And then surgery is kind of free in your country, where if you come to America, it's super expensive. So it's just a lot of pain and frustration on both ends, to where I don't do Canada, but I do other out of country. A couple people from New Zealand, a couple people from Australia, a couple people, no one really from Europe, a lot from the Caribbean. That barely counts just because it's just across the pond. Let's do a couple more things. So does cervical cord compression cause numbness in the feet and toes? It definitely could. That'd be something called cervical myelopathy. If you search my last name on YouTube and spinal cord compression, you'll see I have a couple of videos on cervical myelopathy, and you can see it there from user 174. Hello from Wales. Good to see a friend from Wales. And Peely, good to see you. In your opinion, do you have a choice? What time of the year is best to have a spinal fusion? No, I would kind of say, I don't know, in the winter. So that way you're not missing pool season. We live in Texas. It's hot. We try to get in the water whenever we can. And usually after surgery, I don't want you in the water. You can shower whenever you get home a couple days later. But no matter what surgery I do, laminectomy, microdisc, whatever it is, I don't want you submerging in a water pool for 6 weeks after surgery. Sometimes a little less, sometimes a little more, but 6 weeks when I see you. So that's 6 weeks burning up in the summer while your family's all having a nice time. So that's only my thing. Don't do it before deer season. Yep. Oh, hey, I recognize that name right there. How about that? There's some people right there I see. And that's nice. I see a lot of returning patients here. And so far, no one said anything mean, which is great. And that's just kind of proof of the pudding. All right, so let's get to a couple more things here. So again, just to kind of summarize here, spinal stenosis, and is there a cure for spinal stenosis? That's a great question. I wouldn't say there's a cure in terms of you can get rid of it from the entire body forever. That's just not something that's in the pipeline. That'd be just getting rid of arthritis or getting rid of tumors. That's another thing that it causes if you have a tumor that goes there, or infection, neoplasm, stuff like that. Those are all things that could squeeze the nerve. So getting rid of all spinal stenosis, not traditionally going to be possible. But if you have spinal stenosis at a particular place, either in the neck, 1 or 2 levels, lower back, 1 or 2 levels, there's great options. In the lower back in general, that could be a microdiscectomy or a laminectomy. If it's instability, then to cure it at that level, which is not, it's not curing the whole body, it's just at that level, that'd be a fusion. If you have the instability, it's a 1 level or a 2 level, just depends on what's going on. In the neck, a little different argument. In the neck, there's not a ton of non-fusion surgeries out there. There is a laminoplasty, and sometimes I have a patient with 1 level disease and they come to me because they want a laminoplasty, the non-fusion. But in general, a laminoplasty has to be multiple levels on the back. Like, it's a good surgery, I like it, but it's not like, even though it's non-fusion, it's still a big surgery. It's on the back of the neck. The incision's not small. It's, again, I use this pen just because everyone, this is hard to see what size this is from home, but the incision might be about this big, honestly, on the back of the neck. And so I use a laminoplasty. It's got to be multi-levels, not much neck pain. They have to have appropriate alignment. You can't do a laminoplasty if you're chin on chest. So there's definitely a subset of patients that get laminoplasties. I'd say it's a very common surgery. The people that are out of state, that's a common one, because they're searching me out because I'm the only one that will do the laminoplasty on them. But it's a good surgery. Some surgeons were never trained to do it. It's kind of a more old school surgery, but sounds like it's kind of making a comeback if there is such a thing of trends in spine surgery. But a laminoplasty is a non-fusion surgery on the back of the neck. You also could do a cervical foraminotomy, a little pilot hole and tunneling out that nerve root on the back of the neck. But you can, but you really shouldn't use that to address spinal cord compression. Let me say that one more time. On the back of the neck, you could make a little pilot hole, but that's better for like a pinched nerve shooting down arm pain, unilateral. There's got to be a lot of factors to do a cervical foraminotomy. And I do maybe like 1 or 2 a month. And some of my buddies, this is not me being special. It's just we had a high training in it. Don't do them ever, just because there's kind of a medium failure rate. And if you're like, well, failure, I don't want a surgery to fail. What does that mean? Having another surgery in the next like 6 months. And if you're like, oh, is that bad? Look, it's not the most powerful surgery in the world. Go in there and just trying to make a little pilot hole. And it's one of those things I say, sometimes like if your house has a bad foundation issue and you try to paint the walls and make it look good, well, the foundation issue is still there. And that's why in the neck, a lot of times you need the fusion. So it's not infrequent, unfortunately, to get a cervical foraminotomy and like it gets you some better, but not all the way, or it comes back. And then, okay, well, you tried. And then you can do the disc replacement or the 1 level fusion or 2 level fusion, just depending on what it is. So sometimes you're like, oh, my surgery failed, I had to get another one. It's like, well, I'll tell you what, if I did a fusion, I bet it wouldn't have failed, whatever your failure term is. But it's just a bigger surgery. We kind of go from there in terms of what those descriptions mean. All right, everyone. Well, I do think I have to go here in just a minute. So let me just kind of do some rapid fire questions. Thoughts on spinal cord stimulators? Mixed. I maybe see one patient every like 6 months. I say to consider it. But to be fair, usually if I'm seeing them, they have a pathology, I can fix it. Or like they had a spinal cord stimulator and it sucked and they're still in pain. Then, but I would say in general, that's a little outside of my field, believe it or not. Spinal cord stimulators are good. I'm not like 100% supportive on them, but I'm not against them at all. If that's a terrible answer, then I agree with you. From Humble Guy, my own product. I'm in Dallas, Googling your name and nothing comes up. Well, that's a bad search engine optimization. I would search Chester Donnelly, Dallas spine surgeon, and hopefully that comes up. But it's Texas Spine Consultants. What about 4-level fusion? That's a big fusion from Javers. I mean, we do 4-level fusion. It's just pretty rare, honestly. So you're telling me that's like L2, L3, L2, 3, 3, 4, 4, 5, 5, 1. That's a big surgery. In fact, if I did that, I'd probably go to the pelvis also. It's just a big surgery. And you're like, yeah, I know it's a big surgery, doc. That's why I'm asking. It's not infrequent. Maybe I just try to do 2 of the levels, the symptomatic ones, and then call it a day. And, if that results in a failure because a year later you need the other 2, well, we tried at least. But 4 levels is not super uncommon, but it's just a big surgery. And if you need it, you need it. I would think of it that way. Anyone with severe foraminal stenosis L5S1 experiencing excruciating type in the lower tops of the feet, tormenting burning pain. Yep, from Cruise Hill. That's not terribly uncommon. That's where the L5 nerve root actually goes. It goes down the side of the thigh, front of the calf, or sorry, front of the leg, and it kind of wraps around to the top part of your foot. So that's a very classic L5S1, and that's something where you can do a foraminotomy, a microscectomy, or a fusion to open up those nerve tunnels definitively. Just depends on a lot of things. From Victor Lopez, Recum Tecum. Yep, that's we went to med school, Harvard of Texas, is what they're also known as. From Deborah, third laminectomy with a fusion. The first two failed. Told 25% this one failed. Do you agree with the number? I don't know. I don't think I agree with the number. I mean, I don't know anything about your case, but I'm making this up. Someone might say, well, it's my third surgery. The first two failed. Well, I see that every now and then. It's like they had a microdiscectomy 10 years ago. They did great. And then some stenosis came back. Then they get a laminectomy. And they're like, well, that microdiscectomy failed. It's like, I don't know about that. It's like you still continue to get arthritis in the body. It wore out. It held up. And, you get more arthritis there. So is that one a failure? I don't know. Fine. So you get the laminectomy. But then you still keep getting the arthritis. They really didn't want to do a fusion on you. But now you have to get the fusion because you've just lost all that foundation. It's lost that instability and do the fusion. It's not like, I don't know. I'm not trying to defend all spine surgeons because I think some of us really suck. But I don't know if I'd say the microdiscectomy 10 years ago failed, the laminectomy 8 years ago failed, and then 2 years later you had to get a fusion. That doesn't, and I'm not saying that's your case. I don't know anything about your case, but I would just sometimes if you're reading online forums and they do that. Cliff's asking a great question. Dr. Alexander Butler in New York City. Have you recommended him in the past? I have. He's a great guy. I text him all the time. I like Alexander Butler a lot. When is ablation not recommended? That's a great question. I don't recommend an ablation if your issue is shooting down the arm or shooting down the leg, because that's a pinched nerve. So you don't want to do an ablation in that case. That's a pretty easy thing there. Or if you have spinal stenosis and that's your symptom, then don't do an ablation. Just open the spinal stenosis. What's the best implant company? I don't know. There really isn't one. Some have great. They're all really, let me say that a little differently. There's not a best implant company for real. Like screws are pretty similar. Some of them have different little neat ways to do it, but then maybe they don't have the best bio or they have the best cages. There's a couple of companies that have some of just the bigger stuff. There's probably like 3 big spine companies out there. I don't know. There's not a real great answer on that. My niche, well, I don't know if it's niche. I don't advertise it a lot because I kind of run out of stamina on doing this stuff. But I try to use Dallas companies because I'm a Dallas-grown guy, Dallas-born guy, and there's like 15. I'm making that number up. Spine companies here in Dallas, and so I try to like keep it local. Try to have like my business go to people who have like their families in the same DFW area, root for the same sports teams. Try to keep it here. I kind of make jokes that there's a lot of big spine companies in California. Well, I'm trying to keep my spine business here in Texas and support the local economy here in Dallas. That's not 100% true. I'm sure I use companies that are in South Korea, Florida based. Maybe they're based here, but they get all their stuff in Europe or something like that. But in general, what's the best company? I don't know. Me as like a very Dallasite guy, I try to use Dallas companies just to support the local economy. They probably don't need my business and they're doing just fine without me, but maybe it makes a funny little plug on social media. Who knows? Do you have any videos where we can watch you talk about specific procedures? Yep. Go onto YouTube. I have a lot of stuff on YouTube. I think it's like 450 videos. I just saw it the other day. But YouTube's where pretty much everything I do on TikTok, I'll put on YouTube. But maybe it's a little more organized. All right, everyone. Well, on that note, I am going to go. I think there's certain ways on social media you can like hit alerts. And then when I go live, it'll tell you when I'm on. You can get your questions on. And that would be great. All this are recorded and put onto YouTube, which is just a nice advantageous thing I try to do for my, not patients, but just people, because you guys aren't my patients. And we'll go from there. But just as my 1 minute plug, I'm a spine surgeon here in my home city of Dallas, Texas. We do disc replacements, which I never even got to talk about, in the neck. Partner does disc replacements in the back. Do big scoliosis fusions, education, foraminotomies, all that stuff. 6-person spine surgery group here in Dallas, Texas. And born and raised here, use all the minimally invasive stuff, and it's all pretty good. So from that note, I got to go. Some life things I got to get to, but great talking with y'all. I could do that. There we go.